healthy development versus what we see when normal development goes outside the boundaries that is considered healthy mental well-being and behavioral well-being. And so I just want to just kind of bring that and bring that to light right at the moment. But the first thing we should really talk about is, how do we define abnormality? And there's really a couple ways. There's three ways, and then we'll talk about a statistical way here in just a minute. But one way that we often go through life and decide whether someone has an abnormality psychologically or socially is from what's called the egocentric perspective. Okay. And if we would have done the social psychology part, this is where the individual determines abnormality based on their own way of thinking and their own way of behaving. And anything that's not within their range of behavior and mental processes, we consider as abnormal. Okay, so for example, when someone's not living their life the way we did and they're constantly having trouble, we assume that because they're not living our way and our method, then that's what's causing the trouble in their life. Okay. What plays into that egocentric view are social norms and cultural norms. So social norms are anything that violates what would be considered socially appropriate. And, we can think about extremes such as homicide or something like that. But social norms are those things that within a community, within a family, we set for ourselves, and anything that deviates from that, then we consider abnormal. And then there's also the cultural view, okay? And the cultural view is, what standard does the culture set for a given thing to be considered disordered behavior or the like? And probably, and I think I may have brought this up in this class before, but things like attention deficit hyperactivity disorder, or ADHD. When we look at ADHD here in the United States, it's diagnosed at about a 13% rate. There's actually some more current research that suggests that it's actually higher than that. But we often diagnose kids with ADHD, and our methods of treatment tend to be medication. And then if the parents and everything are on board, we'll do some behavioral cognitive type of therapy to help the individual control their attention issues or their hyperactivity issues. Okay, but usually in our culture, the first run is medication of some type. But and we're always saying, well, the United States has a Western cultural view of the world, and so any Western culture would kind of fit that way of thinking about that disorder. But when we compare ourselves to some of the other Western cultures, we find that the United States is kind of unique. So, for example, when we look at France has a diagnosis rate of ADHD that is less than 1%. And what makes that significant is if we look at disorders in France, when we look at things like diabetes and those types of things, they kind of equal what the United States has. Okay. But their view of ADHD is much different than ours. In our view, we think it's an issue with the child. In their culture, they think it's an issue with the parent and the family system. And so their treatment modality is to go treat the parents and treat the family system and the social system instead of the individual. And they find that their diagnosis rates is a little bit different based on their cultural view of what disorders look like in childhood. So here in the United States, we take more of an egocentric view. So we put the onus of the disorder more on the child, whereas other cultures put the onus of responsibility on on the family. Now, that doesn't mean that with all disorders, it's an issue with the individual, because again, if we look at United States culture, we talked about, when we talked in the developmental section, about attachment disorder in young children. And I mentioned that attachment disorder treatment is 90% with the caregiver and parents and only 10% with the child. And that's based on social norms. Attachment has something to do with the system, where we view ADHD as something that is disordered with the child. Okay. So we have all these different ways of defining what would be considered abnormal. But I kind of want to take the statistical view just so that we understand this. So I don't know if we mentioned this before, because I know that, but any behavior follows what's called a bell curve. Even when we look at growths of plants, we'll find that the majority of growth of plants, the majority of behaviors follows what we call a bell curve, where the majority of individuals score somewhere in that middle range. When we look at this, so what we have in this area of the range, this represents 95% of people's behaviors, okay? Which puts 2.5% on this tail end and 2.5% on this tail end. So if we were going to do something like measuring sadness to happiness, okay, because they tend to be the two antagonist things to each other. You can't define happiness without defining sadness, and you can't define sadness without defining happiness. If you're in the sad range on this area and you're in that 2.5% on this area, this is something that you would look at from a clinical perspective. And you would go, why is it that these individuals are scoring so much more on the sadness side of the scale? What's going on? If, on the other hand, you have individuals who are scoring on the upper end of happiness in this 2.5% range here, this is known in psychology as positive psychology, which really started around 1999 and has really come to show what these individuals want to know is what sets this 2.5% of people different than the larger population, and definitely larger than this other population. Okay. So this is going to be kind of the definition that we're going to use for the sake of this course, because again, when you take the egocentric social norms and cultural norms, it really doesn't capture, you know, what it is when it's put on some type of measurable scale. Okay, but this is another way, and you'll find we're going to go over what's called the DSM. It's the Diagnostic and Statistical Manual of the American Psychiatric Association. This is kind of how they defined it, but I'm going to get a little bit more into that because it's a little bit more complicated than just this scale right here. Okay, so I want to talk about abnormal behaviors in and of themselves, because no matter what in life, we're all probably going to experience this at some point. We're all going to experience sadness or elation. We're all going to experience aggression. Sometime in our life, we're going to have delusional thoughts or paranoia. Okay. You know, even when it comes to thoughts of harming oneself or harming others, we all will go through that type of behavior. Okay. Believe it or not, even if you are the most healthy person in the world, everyone will have a hallucination sometime in your life. In fact, we hallucinate all the time. And I explained this when we were talking about sensations and perceptions. Technically, we have a blind spot in our sight, but through the hallucination processes, our eyes fill in those blind spots. So technically, we hallucinate anytime we have our eyes open. But again, people will have some type of auditory hallucination or something that deals nothing with drugs or alcohol or abnormality. But these abnormal behaviors are a part of life. And that's something we need to keep in mind when we're looking at people who are going through these different behaviors. When we get concerned, and we'll go over this in much, much more detail, when clinically we get more concerned is when we have a combination of these abnormal behaviors that are consistently combined over an extended period of time. Okay, so for example, most everyone in this class will have a depressed mood, okay, where you just feel down. But if it doesn't include things like irregular sleeping, irregular eating patterns, things like worrying, things like need the repetitive behaviors, sadness, all of those things, we know that a person in a depressed mood, greater than 90% of those individuals, that depressed mood will go away on its own within 90 days. Okay. But when you get that depressed mood and it's combined with these other things, that tends to be more clinically significant. That's when we start to get really concerned about the individual. Okay. I also just want to, before we get into this in much more depth, is I want to separate the issue of mental health from mental illness. Okay. Mental illness is when we have a diagnosable disorder that can be treated through biological means such as medication or surgery, social means by increasing the social connections of the individual, and psychological treatment dealing with abnormal thinking processes. Okay. That's different than having a mental health issue. And the reason why this is important is you hear about gun shootings and all these things that people do. And when we say we need to invest more in mental health, the assumption is that that person was mentally ill in some way, that they have an illness. But there's a big difference between mental health and mental illness. Mental health is when we're going through life and we maybe have really bad health habits, eating habits, exercise habits. We don't socially connect with other people and we feel loneliness, for example. Or we constantly think that we're a failure of some type and we're disconnected from the world because we have these thoughts, okay? That's mental health. Mental illness, as you will see here in a few minutes, they have to have some additional criteria, okay? And I like to think about, when you think about the connection between mental health and mental illness, I'd like you to think about things like type 2 diabetes, okay? What leads a person to type 2 diabetes is someone who overconsumes sugar, processed food, those types of things. And so the body has to work harder at metabolizing the insulin naturally in the body, okay? But not everybody that eats processed food or high sugar diets will end up with type 2 diabetes, okay? It puts a person at higher risk, but it doesn't necessarily mean that the person will end up with the illness. And that's why when we look at things like school shootings and those kinds of things, and they say, well, the person didn't suffer from a mental illness. They were never diagnosed with an illness, but there was definitely mental health issues going on. So they tended to be very lonely. They weren't able to socially connect with their peers. They felt rejection constantly, probably bullied in some way, and they're experiencing mental health issues. But a school shooter doesn't necessarily, or a mass shooter doesn't necessarily have a mental illness, because once it gets to a mental illness stage, a person with full-blown depression or full-blown anxiety doesn't have the energy or the desire to put in the planning and the execution of such a horrific act. That's someone that is suffering from mental health problems, not necessarily an illness. So I wanted to start with a conversation about these two different processes. So in conclusion, yes, mental health issues do put you at higher risk of mental illness, but not always. And mental health issues, just like bad eating habits and bad exercise habits, can lead us to unhealthy behaviors. Okay, so I just wanted to bring that up before we begin. The other thing that I want to bring up before we get into a full conversation about this is I do want to remind everybody that this is an academic lecture and it's academic in nature. And so if you are being treated with a mental illness, you're on medication, or maybe you're in treatment for something, based on this discussion, please do not stop taking your medication or stop your treatment. You really need to get a hold of your mental health provider or your physician who is treating you for something and have that conversation with them. Because again, this is an academic lecture. It's not a clinical lecture, okay? And so please don't, one, label yourself with a disorder because you see common symptoms. And two, if you have been diagnosed with a disorder, but you're hearing something from the academic literature that suggests maybe you shouldn't be having treatment, please don't take it that way. Please go see your medical provider and have that discussion with them. So just want to put those cautionary tales into place before we move on. But let's talk about defining what a mental disorder is. And this area in the white comes directly from the DSM, as I talked about before. But it really comes down to these qualities that we see here in the dark area that has the white lettering, okay? And I just want to draw attention to the first thing is a mental illness is first diagnosed by having a cluster of abnormal behaviors, okay? Meaning that, as I said in the beginning, a depressed mood, sleep issues, whether you can't sleep or you sleep too much, loss of motivation to go to a job, eating changes in your life, those clusters of behaviors that are happening together is what we would define as depression. So if I were to put kind of a circle here, so this circle, and I'm going to put an S, represents sleep. This one here represents motivation. And I'll do that by an F. This one here represents a depressed mood. And I'll do a little arrow, depressed mood. And let's just add another one here. Let's go with another circle for eating. And I'll represent that and for the changes in eating. And when we talk about a disorder, what we want to know is we notice that there's this overlap between all four of these symptoms, right? And this overlap can be represented by people within this little range right here, okay? And so what we want to know from a disordered perspective is why is it that this population right here tends to have these clusters of abnormal behaviors, okay? And we do this by doing what's called a cluster analysis. It's a statistical procedure that shows how statistically things are related with one another, and it kind of shows us, hey, we notice within this population or these individuals that these things tend to cluster together. And then it gives us the proportion of the population where these abnormal behaviors cluster. Okay. So the first thing we need to understand about a mental disorder is that things like depression isn't just about being in a depressed mood. It's not just about motivational issues. It clusters with things like sleep and eating habits, and you have to have the motivational issues along with the depressed mood in order for this to be considered what you would consider as a clinical issue. Okay. So we have the cluster of behaviors. The next thing we need is that those behaviors need to be deviant in some way, meaning that the whole population right here doesn't normally experience these symptoms together. That there's something different about this, and it makes it so a person behaves differently than everyone else. So, for example, with the sleep, maybe they sleep all the time, and then they start having work issues and not being able to show up to work, or when they do show up to work, they're not mentally there. Okay. This second thing is it needs to be distressful, meaning that it has to be causing the person distress. They recognize, in other words, that there's something wrong with them. And then when we look at children, we also include, not only does it create distress for the child, but does it create distress for people around the child? And we even look at this into adulthood. So when, when someone is really diagnosed with depression, and they might interview the spouse and say, how is this affecting your life as well? And we will look at work and how it's affecting their job. The other thing that we look at is persistence over time. Okay. And this is important because, as I said, things like a depressed mood, when it's just a depressed mood, greater than 90% of the time, it will alleviate itself within 90 days. But when it goes beyond that is when we're going to start to get concerned, and we're definitely going to look at these other symptoms that they're experiencing and see if those are persistent over time as well. Okay. And probably the most important that at least the clinical and the psychiatric people argue is that it must be maladaptive. Okay. Meaning that it's not adaptable for the individual, that they're experiencing loss of social connection, productivity at work, things like not meeting their basic needs, such as housing or food or those types of things that kind of keep us as what you would call a survivable species. Okay. So it has to have some type of a maladaptiveness to get into the disordered range. And as you could guess, if we were to go back to our discussion about psychopathology, these 4 reasons is the reasons that that's not considered a disorder. Okay. Because while we have a cluster of behaviors that tend to be persistent over time, it's not distressful for the person. They don't see it as deviant or maladaptive. Okay, they find adaptive reasons for the reason they're behaving. Okay, so again, just going down these four criteria with the cluster of behaviors, that's what we define as a disorder or disordered behavior. Okay. When we look at the history of mental disorders and stuff, we do want to look at, again, how worlds have looked at this as a issue. And the first one is the moral corruption theory. And this is abnormality is caused by some lack of moral fortitude in some people. So you're depressed, or you have anxiety, or you have these maladaptive attention issues because there's something morally wrong with you. Okay. And this is why it's so difficult to have open and honest conversations about mental illness, because even though we're trying to change the perception of mental illness, we still culturally feel like if we admit to having depression or having bipolar, that that's something wrong with us as a person. Okay. And we also have to look at not all what you would consider mental health disorders were considered morally corrupt. Okay. So if you look at Western culture as an example, at one point in Western culture, if you heard things that were not there, if you saw things that no one else was seeing, if you had times where you kind of disappeared on everybody and your thought processes were different than other people, you were actually looked at more of as a guru or a religious entity or someone who would be codified within a religious perspective. Okay. But when you look at history, if you have someone come and saying, I'm just using this as an example, this is not a hit to anybody's religious belief, but if we had someone today who said, for example, I'm the son of God, I can see angels, I hear my God all the time, and I see the world very differently than anyone else, we would probably be looking at a diagnosis of something like schizophrenia. We would probably consider putting them on Thorazine, because today that would be considered a abnormal behavior or an abnormality with the individual. But we look 2,000 years ago, and those people are codified as gurus or religious leaders or those kinds of things. So our idea of abnormality has changed over time. Okay. Now, going back to the negative results of society, we can see some different types of treatments that were given based on this moral corruption theory. Okay. The first one is what's called trephining. Trephining, we actually have found issues of historical ideas of trephining both here in the North Americas or the American continent before colonization. And we definitely see it in the Asian and the Western cultures as well. So this isn't something that is kind of isolated to one type of belief system. But basically, trephining is this: you drill a hole in the top of someone's head, and the idea behind it is that supposed to release the quote unquote demon that is possessing the person. And so that's one of the earliest types of treatment for mental illnesses that we find, not only in Western society, but the American indigenous societies here. There's definitely examples of this with the Aztecs and cultures like that. The second form of common treatment for people with mental illnesses is banishment or social isolation. When we look at the early, for example, the best example is you can find the idea of banishment in a lot of fairy tales about the dark forest. There's ghosts and there's demons in the forest, so you don't want to leave the community because of these evil forces that exist in the black forest or the demon forest or whatever it may be. And this had two reasons. One, it made sure people didn't leave the community. One, but two, the idea of where that came from is those were people who had mental illnesses. And so they kicked them out of the village. And it was believed that their evil spirits would still stay in the forest long after the person became deceased. So it served kind of a dual purpose. One, it scared people from going into the forest and staying in the community. But the myth about it is that it became this idea that if you went in the forest, those evil spirits, those demons, still existed in the forest. Uh, the other form, if we get into the 1600s, 1700s and stuff, we can see in the witch hunts, which we'll talk a little bit here in a little while about the famous witch hunts that occurred both in the Europeans and in the American continent. But what we should say about this is the majority of individuals who were hung or burned at the stake tended to be women and elderly people who did not meet the social norms of that community. So they practiced something with nature or something like that. And then they also were seen as having this, again, this moral corruption. They were corrupted by the devil, as an example, or by demons. Okay. And we do see, not in all, but in a lot of indigenous communities, we see the belief about the influence of bad spirits. So, if you, in the Tanahatham nation, we see the influence of things like the coyote versus different other types of animals, and that influence behaviors. But again, I want to say this, we got to, in the Tanahatham nation, there's a lot of different interpretations of the influence of different animals. And that's what we need to keep in mind when we look at the indigenous experience. So again, trephining is one of kind of the earliest examples of how to deal with mental illness. Again, this is trephining. You see they're putting a small hole in the top of the person's head. And this tended to be the belief that then it would release the demon. What they didn't know in the early days, and this is an example of it in the Western culture, so they actually had a device that clamped the person's head, and they kind of use this kind of corkscrew idea to then release, again, in these cases, the demon that were inside. What they didn't know is that they actually, in a lot of cases, were dealing with people with TBIs, or traumatic brain injury. And the reason why this actually was seen as a good method of treating mental illness is that for people who had, for example, traumatic brain injury, and then they started acting abnormally, trephining would actually allow the brain to swell. Whereas in a normal TBI, where that's not permitted, basically the brain will squish itself inside the skull. And so we're going to see trephining not only in the early years, but we'll see this into World War II, even in Vietnam, where you'll see this trephining idea in order to help people who have traumatic brain injury. Now, today, I will say they found that putting a person's head on an ice pack or a cooling chamber is much more effective than drilling a hole in someone's head. So today, instead of drilling a hole in your head, because that can become easily affected, and so that's also I want to rewind for a minute. Is the reason why trephining was so successful is one, if it was a TBI, it would relieve their symptoms. But two, if they passed away, that was also a successful treatment, because the demon was then released from the individual, and the person ended up being forgiven for their sins, as you would say. But it was mainly due to some type of infection. But we see trephining, again, clear up through the Vietnam era as a common treatment for TBIs. So let's also look. So this is just kind of showing, trephining has been around for quite a while. And so this short little video, there's not much sound on it. This was a early example of trephining that was done commonly in inpatient treatment centers before the advent of medications and chemical routes of relieving different types of mental illness. So we'll just loop this really quick. So you see, this is basically a hand drill, and they're drilling at the top of the person's skull. In this modern form of treatment, it's not necessarily the release of a person's demon, but it was believed that what was causing mental illness was the swelling of the brain, kind of like with TBIs. And so this became a very common inpatient type of treatment. And then you see this is what's called a stent. So they would put a straw-like device into the skull and allow the liquids to leak out. So if there was any, for example, excess leakage in the skull area, this would drain all of that excessive liquids or excessive blood. So that's what they're sticking in the head right now. And then they finally are there. And we don't necessarily need to watch the rest of this. This is just kind of the idea behind modern forms of trephining. But I should say that the idea of letting out fluids or something isn't really the only method that we commonly saw for the treatment of different disorders. So, for example, if we go to the Greeks as an example, they kind of were the ones that first came up with notions of mental illnesses, but it was based upon different bodily fluids that the person had. So you could be sanguine, which means that this is kind of the optimistic side of the continuum, where on this other side, if you had like black bile, that meant you were melancholy. Melancholy is our first form of depression. If you had too much phlegm, it meant that you were unemotional. You didn't experience emotions. If you had yellow bile, this meant you were choleric-y or had bad temper. And so what came out of this, and I'm going to say, that's the Greek term for bodily fluids is humor. And so I always like to say this: if you're saying someone is humorous, you're telling them that they have a different type of blood or liquids in their body. They have a different color of bile or a different color of urine or something like that. So the term humor that we use today actually came from this Greek notion that good things and bad things happen because of a maladjustment or a different adjustment of the different humors or the different liquids within the body. Okay. So this led to one of our early treatments for mental illness, and it was called bloodletting. So you had someone come in, they were either severely depressed or highly anxious or hysterical in some way. And they basically put the person on a table and they would put a needle up into their back and they would drain blood out of the body. Okay. Now, if you think about someone who is hysterical, this was a very, very effective treatment because what they would end up doing is draining so much blood out of the person that they were almost on their deathbed. So their symptoms of hysteria would go away. Because they were so lethargic because of the lack of blood, they weren't doing much of anything. Okay. And so this led a lot of individuals through the Greek times, and we can see bloodletting occur clear up through the Civil War era into World War I and a little bit in World War II. If some of the cultures who use leeches to fix different disorders, this is another form of bloodletting, is leeching the body, and we can see in some cultures that still exists today. Okay. From a mental health perspective, the next stage of bloodletting came when we started using verbal types of treatment. So there's something that's called the cathartic release. All right. And what the cathartic release is we got to look at this from two perspectives. It's it comes from a theory of anger, that the reason why someone has an anger blow up is because all that anger and frustration was building up in them. And then there was some trigger in the environment that let all their aggression out. Okay. And so it's called the bottle theory. Okay. However, and so we have that, and then we have other types of mental illnesses. Okay. And the idea, the cathartic releases, is instead of draining blood, you're letting the person release it verbally. I call it verbal vomit, if you want to use that term. And it comes from actual later research that showed that approximately over 85% of individuals that go to treatment, to some type of therapy, over 85% of them never return after the first or second session. All right. And of course, we wanted to know, why didn't they come back? Did their symptoms get worse? Did they have an issue with the therapist? What's going on? Why is it so many people don't come back after the second session of therapy? And what we found is when we went back and did interviews, greater than 90% of individuals said that they had a relief of their symptoms. And it came back to when we look at qualitative interviews, a lot of the individuals said something like this. They said, it was the very, very first time in my life that I was allowed in a safe place where no one's going to judge me. They're there. It's confidential. They're not going to go tell my wife or my husband or my family. And it's the first time that I was able to talk about these issues without judgment. And just by that process of having that non-judgmental environment to actually talk about things, this relieved a lot of individuals' depressive or anxiety symptoms. Okay. So there's a check mark 1 for fact on this one. Does having that moment of release help people? The answer would be, yeah, it can. However, when we look at the bottleneck theory about anger, we actually find that catharsis with anger leads to more anger. So the idea that releasing your aggression out, releasing your anger in some way will make the person less angry is actually fiction. That's false. What we actually find is that actually makes a person more aggressive, and more even going to the level of violence with aggression. Why? Because they're being reminded of what made them angry. And so we find that when so does cathartic release work with some disorders? Yes, we can look at things like depression. We can look at things like anxiety. It can have a relieving effect. But when we look at other conditions such as anger and violence, we find that cathartic release doesn't work. It actually makes the individual worse. So there's fact to fiction, but it all does lead back to this idea of bloodletting and letting the fluids out of the individual. And then it went to the verbal version of it. But this is kind of the legacy of the Greek thought of mental illness. And as I mentioned earlier, probably the theory that is most associated, especially with Western culture, about mental illness is the witch hunts, where we had individuals who may have been acting more hysterical, more anxious, mostly women and older people. We thought that they had some type of moral issue with them. And so we decided that the best thing to do them would be to release them from their contract with the devil through burning them or some other forms of violence that we see. But what we do get from the witch hunts that has led, I know this is strange to say, is more humane ways of treating, but also has also led to myths is while these procedures were not necessarily healthy or necessarily led to an accurate diagnosis of a witch, we see the development of a systematic way of diagnosing disorders such as witchcraft. Okay, when we look at the heydays of the witch hunts, we see individuals who became quote unquote experts in identifying witches using different systematic methods. So, for example, the float test. If the witch drowned immediately, she was seen as someone who may be possessed. There were individuals who were called prickers. This is where specifically more often with young females, they were stripped naked and the pricker would prick all the hair off the young lady and then would explore her body for what was called the mark of the devil. And we had other type of interviewing methods. But what we're starting to see, even though it came from a hellish type of situation, is we're seeing the development of a systematic way of identifying different disorders. And again, where it's going to lead us is into the Freudian era, where it's going to be assumed that only a person with a certain type of training, a certain type of expertise can diagnose and treat mental illness. Okay, so you either a clinical psychologist or a psychiatrist, you have certain type of training that then makes you some type of an expert in identifying different mental illnesses. And we can trace this idea back to the witch hunts in Western culture. And so that's kind of the one, it did lead to a professionalization of the field, but two, it also hurt a lot of people. And it gives us a myth that the only person that can help someone with a mental illness is someone with some type of special expertise. But by the end of Wednesday, I hope that we can get rid of some of those myths surrounding expertise and helping people who have mental illnesses. When we look again, in not all, but a lot of Native American communities, we see the idea of a medicine man. So this is that person who has seemed to have certain skills or ordained with special ways of understanding people. And we see, okay, so we saw the notion of this occurring in Western culture, and now we look more at Native Americans. And again, I hate, because we can't put them all in one basket. I want everybody to be careful with this part of the lecture. But what we see in a common thread with medicine men and whatnot in Native American communities is we see this dysfunction arises from a disharmony between the person and nature. And they're more likely to focus on the person's journey and what led them away from nature. And we also see, though, and this is a lot different than with Western culture, is we see that the community is the one that takes care of the individual who cannot take care of he or she self. Okay, so we see as a divergence from Western culture where the person is put away somewhere, is socially isolated somewhere. We do see this differences among Native American communities where they actually try to help the person first. They try to bring them into the community and make them a whole person again. And then if the behaviors don't change, again, on the community level, not on an expert level, on a community level, sometimes the end result would be the community coming to consensus that the person needs to leave the community for a given amount of time or permanently. So, but again, what I would encourage you all to do is to look at your specific Native American community to kind of do this kind of historical understanding of mental illness, because this is a wide spread blanket that doesn't fit all communities that we're aware of. So I just want to put that warning out there on that issue. All right, we'll end with this today, but we're getting into now the modern theoretical views of mental illness. And again, we've kind of talked about this in the personality section. And so I'll kind of briefly elucidate on these different schools of camp. So we have the Freudian psychoanalytic psychodynamic, who believe that dysfunction is driven by unconscious drives and desires that became dysfunctional early in childhood. We see the humanistic theory. This is when an individual fails to strive to one's potential, and is out of touch with their own feelings and the way that they are. We have the behaviorist, who believe that mental illness is a development from a reinforcement history, and the environment. So we're starting to see with behaviorism the notion that the environment plays a role in the mental illness process. And then we have the cognitive process, which is more deals with irrational, dysfunctional thoughts or ways of being. And again, when we look at things like the sociocultural, that goes to how a society defines what's abnormal and what is a disordered behavior. And then we have the bio-neuroscience issue or method, which uses more of a medical model, where disorder is seen as an organic problem or a biochemical imbalance of some type or some genetic predisposition. And on Wednesday, we'll talk about mental disorders that are what's called more organic versus more environmental. And so, for example, when we say organic, we know that the biological component plays a larger role than the environment. So we can look at disorders such as bipolar disorder, schizophrenia, and a few other disorders that tend to be driven by more the biochemical organic problems than by the behavioral or cognitive or humanistic type of ideas. Okay. And then just to kind of elucidate on this a little bit more, then we have the more environmentally triggered disorders, such as depression and such as anxiety. Now, that doesn't mean that they're less than someone who has bipolar. It just means the genetics and everything play a smaller role in the development of this disorder. And if you think about this again, we have to remember that this is very similar to how someone gets a physical disorder. So we have these unconscious needs. For example, when we talk about type 2 diabetes, this craving for sugar is a common unconscious driver. And we have, the failure to strive to one's potential. So we get into bad eating habits and more lethargic types of living. And then we have a reinforcement history that is reinforcing that those eating and dieting behaviors. And then we have thought processes around it, such as, oh, I'm not hurting my body, those kinds of things. And then we have the organic component. So there is a genetic predisposition to type 2 diabetes. There's biochemical imbalances that happen, okay? My point being is that when we look at these disorders more today, we use what's called the biopsychosocial model, which states that when we look at a disordered behavior, we need to look at the biology that is involved. Okay, so for example, when we get to depression, we'll talk about serotonin. When we get to schizophrenia, we'll talk about dopamine levels. And all of these different biochemicals that play a role in the person's dysfunction. When we look at the psycho part, again, this is cognitive processes, emotional processes, and then the social aspects. Do they have good social relationships? Do they have a good family? Is there violence in the home? Those kinds of things. And it's more this combination of factors that we find drive a lot of the mental illnesses we see. So this will be a kind of we'll look at these three different areas when we look at disorders this coming Wednesday. And just to wrap things up, this is the example of organic disorders. So we have developmental disorders, such as autism. Sorry about that. So autism tends to be more organically driven. Bipolar, which is a disorder. There's two types, but it's when someone goes through a manic phase and a depressive phase. And we tend to find that biological treatments are much more effective than social or psychological treatments. And then schizophrenia, which we'll get into. Again, we're dealing with an individual who has constant hallucinations and disordered thinking, which we'll show this coming Wednesday. And what we find is, again, schizophrenia does respond to some behavioral type therapies, but really it's the medication that tends to alleviate more of the symptoms more than the behavioral type treatments that are available. All right, I'm going to stop here.